Okay, we're back. Professor Tabs talking about pathology in our fourth installment of the basic pathology series. We're talking about necrosis. If you watched the last video, we were talking about liquefaction necrosis and coagulative necrosis, differences in how ischemia represents itself in the kidney and the brain. What happens with the lysosomal enzymes. Anyway, moving on, what I'm going to do now is describe a type of necrosis and you're going to tell me what it is. This has a cheese-like appearance, proteinaceous dead cell mass. No histological architecture is preserved. When looking at it, it looks like an acellular pink area of necrosis which is surrounded by a granulatomatous inflammatory process. So again, a yellow-white cheesy debris. Okay, this is an example you might see in tuberculosis. And this is caseous necrosis. Okay, how about a leakage of pancreatic enzymes? Areas of white, chalky deposits representing foci of fat necrosis. I just said fat necrosis. Haha, I gave it away. Oh well. So it has calcium soap formation, which is also known as saponification at sites of lipid breakdown in the mesentery. So that is fat necrosis. How about fibrinoid necrosis? How would you describe that? Fibrinoid necrosis in an artery. In this case, you would see the wall of the artery with a circumferential bright pink area of necrosis with inflammation. Neutrophils with dark nuclei. That's fibrinoid necrosis. So we looked at fibrinoid necrosis, fat necrosis, caseous necrosis, liquefaction necrosis, and coagulative necrosis. Now we will discuss a little bit about the intracellular accumulations, lipids, hyaline, glycogen, pigments, calcium. Examples of lipids would be neutral fat or cholesterol. Examples of the hyaline could be any proteinaceous pink or glassy substance. Examples of the pigments, they could be exogenous or endogenous. Okay, and here again I will describe what you might see, then you have to guess what we're looking at. Okay, so in this case, a high-powered detail of the fatty change of the blank. In most cells, the well-preserved nucleus is squeezed into the displaced rim of cytoplasm about the fat vacuole. We're talking about a fatty liver here, which is pathogenic, not normal. You might see this as a result of basically three main areas. Do you know those three main areas where you might see a fatty liver? Number 1, obesity. 2, alcohol. 3, diabetes. Okay, next. Cholesterol-laden macrophages in a focus of the gallbladder. This is called cholesterolosis. So what do you imagine you would see when looking at dystrophic calcification of the aortic valve? You may have seen a picture of this before. Well, looking down onto the unopened aortic valve in the heart with calcific aortic stenosis, you would see that it is markedly narrowed. This is the stenosis. As a result of this stenosis, the semilunar cusps are thickened and fibrotic, and behind each cusp are irregular masses of piled up dystrophic calcification. So remember that this narrowing would result in a stenosis. I think I've been having too much catnip, which has caused me to be confused, saying that the narrowing is a result of stenosis or stenosis is a result of narrowing. Well, I'm not going to talk about the causes here, but I would like to explain what is stenosis or aortic valve stenosis. It occurs when the heart's aortic valve narrows, and this narrowing prevents the valve from opening fully, which obstructs blood flow from your heart into your aorta and onward into the rest of your body. So when this valve is obstructed, your heart needs to work harder to pump blood into your body. And this extra work limits the amount of blood it can pump and may weaken your heart muscle. So that's why it's a bad thing. Okay, it's time to move on to inflammation. Now, we've looked at inflammation before many times in different classes, most recently in immunology, where we discussed it in some detail. And here we're going to touch on it again. So remember the sequence of events in inflammation, starting with the normal histology. Well, first we have a vasodilatation. Then we have increased vascular permeability. Then a leakage of exudate. Now remember the difference between exudate and transudate. Remember that transudate is mostly water and the exudate contains proteins and other things. Then we have margination, rolling and adhesion, and there are certain cytokines and things involved in that we'll talk about. Then we have transmigration of the neutrophils, for example, that is called diapedesis. Then we have chemotaxis, for example, the neutrophils going towards where they want to go, to phagocytose, the foreign molecule. Then we have PMN activation. So these are the neutrophils, for example. And then we have the phagocytosis, the recognition, attachment, engulfment, killing, and degradation or digestion, then termination. So what are the possible outcomes of inflammation? First, you could have 100% resolution returning to normal. Then you could have a scarring, which would not be good, because this changes the morphology and the functioning of that tissue. Or we could have chronic inflammation, which is also not good. So those are the three possible outcomes. So when discussing the differences between acute and chronic inflammation, of course we could say, as Dr. Minarsik says often, that you have either polys or monos, and that in acute inflammation you have the, it is the polys, and in chronic inflammation you have the monos, the monocytes, and neutrophils, for example, in acute inflammation. So let's talk about that. So for the immediate response to injury in acute inflammation, what are the signs of acute inflammation you might see notice grossly? So redness, heat, swelling, pain, and loss of function. And what are the components of the acute inflammation? Hemodynamic changes, neutrophils, and chemical mediators. So now let's try to imagine the two different pictures of a normal arteriole and venule, and you might imagine some capillaries in between and the occasional resident lymphocyte or macrophage around in the extracellular matrix. But when there is inflammation acutely, you would see an increased blood flow, and there would be neutrophil emigration, and well, first you'd have increased blood flow, then you'd have the leakage of the plasma proteins and edema, and then there would be neutrophil emigration. So to summarize here, the manifestations of acute inflammation compared to normal: number one, vascular dilation and increased blood flow, causing erythema and warmth; and two, extravasation and extravasation and extravascular deposition of plasma fluid and proteins, and this is edema. And then we have the leukocyte emigration and accumulation at the site of injury. So for acute inflammation, there are vascular events, there are cellular events, and there are mediators. Let's talk a little bit more about the vascular changes. We explained that in acute inflammation we have vascular changes in vascular flow and caliber, and increased vascular permeability. So in response to this inflammation and regarding the increased permeability, remember we have dilatation, endothelial gaps, not epithelial gaps, endothelial gaps, direct injury, leukocyte injury, transcytosis, endo and exo, and new vessels forming. So regarding the mechanism of increased vascular permeability, can you imagine the picture of what is happening? Thinking about the normal situation where we have leukocytes and plasma proteins in the endothelium, and then inside the vessel lumen we have the leukocytes just cruising along, not doing anything. Then suddenly we have a change, and we have a retraction of the endothelial cells. Remember, this is occurring mainly in the venules, and it is induced by histamine. There are no, so histamine would be the main character that would induce this retraction of the endothelial cells. Also nitric oxide, other mediators, and this would be rapid and short-lived within a matter of minutes. Then endothelial injury. This occurs in the arterioles, capillaries, and venules, caused by burns, some microbial toxins. This is rapid, and this may be long-lived, for example, hours to days. How about leukocyte-mediated vascular injury? This occurs in venules, pulmonary capillaries, and is associated with late stages of inflammation. And this is, again, long-lived for hours. And then we have increased transcytosis. This occurs in the venules and is induced by VEGF. So we talked about normal situation, retraction of the endothelial cells, and endothelial injury, leukocyte-mediated vascular injury, and increased transcytosis. So in the next videos we're going to discuss these in more detail, but that is our basic summary regarding the mechanism of increased vascular permeability.